Well, let's now move on to hear from our pharmacist. That's our next P. We have potent, prompt, predictable, and we have protection. Now it's time. We had our physicians, we had our practitioners. Now we got our pharmacists. Time to hit our last P here.
Well, let me take over, Mike. Thank you for including me. I'm joined by Jennifer Goldman. Jen, can you introduce yourself briefly for folks that may not know you?
Absolutely, I'd be happy to. Hi, everybody. I am Jennifer Goldman. I've been practicing for 32 years. I'm a professor at Mass College of Pharmacy, and I run and develop the cardiometabolic program at Well Life Medical in Peabody, Massachusetts.
So, Jen, let me open with a question. You're a professor. How much focus, and you teach PAs, nurse practitioners, pharmacy students, how much focus is on the pharmacokinetics and dynamics of aspirin and a lot of the information you heard here today?
So it was spectacular. And, it depends on where you are in the program, where you're learning pharmacology and kinetics versus therapeutics and being able to put it all together. So I think just learning all that so that you can go out into the real world and melt that and be able to take care of patients. Because when you think about this, as pharmacists, so you're doing inpatient, I'm doing primary care, and every person interacts with a pharmacist, whether it's in the hospital, in the primary care, or out in the community. So that's often the last stop that patients have is going to be their pharmacist at their pharmacy. And so I think that including pharmacists in this patient-centric model to make sure that they have a good understanding of the role of aspirin, and most importantly, which aspirin, how to take aspirin, how to utilize this information to improve outcomes. So I think, I appreciate the utilization of pharmacists within this talk.
So let me ask you, Jen. We throw pennies around in the hospital like they're manhole covers. So for us to start a patient on Vazalore, this will be a struggle here, right? Because we've got centuries of experience, with the aspirin products we have. But if you saw a patient in your clinic, what would be the value add or the characteristics that you would advocate for Vazalore to convince a patient to buy it?
I would probably ask them, do you think you're not worth it? So if you think about the cost of a heart attack or a stroke or something you're trying to prevent, and the cost of Vazalore, I know it's not pennies, so it might be 50 cents a day instead of, the pennies, but what good is really inexpensive enteric-coated aspirin if it's not absorbed? If you look, in my practice, I take care of a lot of patients with diabetes. So if you have people with diabetes, often there's obesity associated with this. So think about everything we just went over. You think about the absorption. You think about the use in obesity. So if you're not utilizing aspirin, you're not absorbing it, you don't get the impact, and you have no outcomes from it, what good is it if it's only pennies? So I think we have to put it into perspective and remind our patients and remind our providers that we're important and you're important, and you can pay 50 cents a day and prevent something.
So part of this is expectation. I go into my local retail pharmacy and it's a jungle to me, and I'm a pharmacist. I see a wall of different aspirin products and different formulations and different dosages. And so what you tell me in the clinic, I now have to translate into an aisle with all kinds of flags and stickers that offer discounts and coupons. What should we be telling patients? Because they're I think in most instances, the one that's going to purchase the aspirin at the pharmacy, at the grocery store, at the convenience store, etc.
Yeah, we need to tell the pharmacists and make sure that all of our providers are educated to the same way that you went over today about if we want to improve outcomes, what do we need to do? And so, yes, you walk into your pharmacy and there's shelves and shelves and shelves of all various aspirins, but we have to make sure that everyone knows which ones they need to get and which ones really they're wasting their pennies. So they're wasting that money to take that if it's not going to actually lead to an outcome.
Mike, if I can have one more question.
Well, if I could just comment before you,
Go ahead.
it gets back to yet another P. It's kind of like that MasterCard commercial. The cost of the procedure, $7,000 to $12,000. Keeping your stent open for 70 cents, a pill, priceless. I think, relative to what we pay for other things, this seems like money well spent to prevent costly and fatal complications. So go ahead, John.
Well, I think it's one of the things we focus on is we do a lot of work trying to find where we can send patients to get drugs at a less expensive cost, whether it's a pharmacy, whether it's a mail Amazon type deal, whether it's a membership club. There's lots of opportunities to try to look around and see where you can generate some savings. My last question, Jen, I'm a big compliance person. We bird dog people to take their anticoagulants. We bird dog people to take their antihypertensive meds, their lipid-lowering agents. And I have my own strategies that I tell people surrounding the daily activities of life. But can you share perhaps what's the secret of keeping somebody on a lifetime of aspirin without interruption and without the problems, surrounding omitting doses that could cause complications?
We have to do what's best to fit into their lifestyle. So you have to have that conversation. If you have to take this indefinitely, when's the best time of day for you to take it? When will it be the most helpful? So maybe that is at bedtime. I think we all just assume stick it in your pill box and take it every morning. But that's what's best for that person? So I think we have to do what we can to decrease the times of day people have to take meds. When anyone has to take medication more than once a day, tend to be less adherent. It's a little bit more difficult to remember. So anything we can do to add to simplify that. So if that means taking it at bedtime or taking it with their other medications, clearly what we've seen is we want to avoid food if we're in certain circumstances. But you looked at that data that Vasilor had little impact when you were comparing that. And I think that this will be very eye-opening looking at that data with the enteric-coated aspirin. So I think it's not just about remembering whether you do it in the morning, it's how to do it, with or without food.
And if I could add, as a practicing clinician, when I talk to my patients, we always say patients first. What's best for the patient? And if I take a couple of extra minutes and I explain to patients, this is important, and this is a medication that I want to onboard. And, fortunately, I have samples in my closet, I have a savings coupon, and I'm actually able to give that right then and there at the point of care. And that drives home to the patient that I'm taking the time out to actually get samples, to give them a savings coupon, and to explain the importance of the differences in aspirin. There's a lot of differences in different medications. People have different effects with medications, different side effects. But if I can at least come and talk to my patient that you're going to have the least side effects, you're going to have the best efficacy, and it's best for you, then I think that compliance part and the understanding and education awareness is achieved, and we have hopefully better compliance with our patients.
Can I ask one more thing? As the pharmacist, I'd have a problem if I don't say this because it had come up about the drug interaction with NSAIDs. So you need, aspirin binds to the COX-1 for platelet aggregation, and so can we avoid NSAIDs in everyone? Well, probably not. So It's actually minimal. So what you want to do is tell patients if they need to be on chronic NSAIDs to take the aspirin at least 30 minutes before, so that it gives time to bind and inhibit the platelet aggregation. Then you can take your NSAID if they have to be on it. So we can't always avoid it.
Well, this has been a great discussion. I think the faculty has done a great job. It's very clear that we really need to educate people about the importance of secondary prevention with aspirin. It remains a foundational therapy. We've got to get beyond just treating stents to treating patients. There is a patient attached to the stent, and they may have an event in another artery. I think we've heard about some new strategies today. I'm going to run through a few of the P's here. That phospholipid coating. Your stomach's coated with phospholipids. That protects it. It just makes sense to coat drugs with phospholipids to protect the drug from the stomach and to protect the stomach from the drug. And this kind of drug is getting across the phospholipid layer in almost like a Trojan horse fashion to deliver the aspirin more safely, but also with those three P's: promptly, potently, and predictably. We've got to move beyond in our practice looking just at the p-value. Was it significant? That's the only thing we seem to care about. That's not right. We've got to look at other p-values. The most important p, as you just said, Dr. Ali, is the patient. Does it make the patient feel better? Do they live longer? Does it improve their outcomes? The second P is these days is price. You can't get away from payers. Is it cost effective? Are we going to be able to afford it? The third P is the physicians. Physicians are risk adverse, and does this fit into their practice? Are they going to be willing to give a drug like some of these newer formulations or the older ones based upon the risk of benefit versus bleeding? And all of these decisions are individual decisions for each patient. We have to look at the risk of bleeding and the risk of ischemia. Well, I want to thank everyone for joining today. I don't know if we have the post-test. Meg, do we have the post-test? There we go. So the post-test, real quickly, is aspirin a class 1 recommendation? Let's see if you learned anything. Click on the answer there, yes or no. Is the extent and speed of absorption with enteric-coated aspirin, is it, compared with regular aspirin, is it speedier, yes or no? And does the phospholipid coating of aspirin reduce gastroduodenal erosions and ulcers, yes or no? And submit your answers. Let's see how you did. Well, thank you. It's been a great discussion. I thought it was a lot of educational content presented here. Thank you for joining us today. This webcast will be archived. You can get CME credit. That's for physicians, advanced practitioners, pharmacists. Everyone can get credit for attending today's webinar. Thanks for joining us. We look forward to seeing you again in the future.